Shailesh. It's a great pleasure to be here. As you know, the uh, American College of Cardiology uh, is big into innovation and sharing knowledge. And so I welcome you all. Namaskar. Good evening to everybody in India. This program is going to be something very unique. The college is, as you know, very international. One of the big things the college tries to do is to spread information, have a good, healthy exchange of ideas. And we hope you participate into this program and we can have a very robust discussion. Uh, Here is the outline of what we are going to be doing today. We are going to have a 2.5 hour session spread over 3 days. It starts with today 4 sessions, starting with imaging in the COVID era. How do you image a COVID patient? Then we go on to imaging heart failure syndromes, advanced echo, and then finally, how do you estimate risk in a patient? You have a treat here. You have a wonderful faculty in alphabetical order. Dr. Blankstein, who is the president of the Society of Cardiovascular CT, will be going first. The second session will be me. You probably know me. I'm Dr. Chandrasekhar. I'm the editor-in-chief of Jack Cardiovascular Imaging and a professor of medicine at the University of Minnesota. Following me will be Dr. Pandian and Dr. Rigolin. Dr. Rigolin is a past president of the American Society of Echo, and Dr. Pandian was the chief of imaging at Tufts, and now he's extended his empire all the way to California, and he is the chief of imaging at the Heart Valve Center in Hoag Hospital. What are we going to cover today and how are we going to do it? We are going to, you can see the grid there. We are going to have 30-minute sessions with 20 minutes of speaker time and 10 minutes of free discussion or question answers. We tried to initially make it an echo session, but the world is moving towards multimodality imaging. And we thought this is a good time to introduce CT and MR into this mix. Some of you are already practicing this. Some of you want to practice it pretty soon. And even if you don't practice it, it is good to know because you will be referring patients for CT and MR. So I think this will be a very fruitful session. Your participation is very important. You have multiple avenues of asking questions after each session. And in the end, there's a 30-minute period. The main important thing is this is an interactive session, and I would encourage you to participate freely, ask as many questions as you want. We will give you our contact information. Even when this session is over, you can keep contacting us to get more information, generate discussion, and sort out your queries. Lastly, don't forget to give us your feedback. We want the feedback both in terms of how we are doing and what content you want to see. You want more echo, more MR, more CT. We can change the program on the fly tomorrow and day after. This is a very unusual program. It's a webinar. Normally we do it joining you and being in the midst of you. We are transmitting from about 8,000 miles away, and there may be some delay in, especially when we are showing you a lot of videos. So bear with us. I'm sure ACC and their partners in India have an excellent multimedia team and they'll fix it. So we are going to learn a lot. We're going to discuss a lot. And most importantly, we are going to have a lot of fun doing it. And I think that's the great hallmark of a good session. With that, I hand over the stage to Dr. Blankstein to tell you how to image patients with COVID. Thank you, Dr. Blankstein. The stage is yours.
Perfect. Well, good morning from Boston, or good evening to everyone there. It's really a pleasure to be able to join this session this morning. I'm speaking to you from Boston, Massachusetts, where we have really had a big battle with COVID-19 for the last couple months. In our cardiovascular imaging center really has had to evolve how we do things to accommodate this. For the next 20 minutes, I will share with you how we have used imaging in general. All the cases I will show you are patients with known COVID or suspected. As imagers in the US and throughout the world, we all had to kind of change how we do things as this pandemic started. And on this slide, you can see various guidelines that were issued from all the major imaging societies. But what became apparent is that when we look at the role of imaging, it certainly depends on the clinical question. In the acute phase of COVID-19, what we saw is patients that present with elevated cardiac enzymes, where the question was, is this an acute coronary syndrome or is this myocardial injury? In the acute phase, we also saw very sick patients admitted to our intensive care units, often in shock, and imaging was used to tell us what is the cause of the shock in some of these cases. And now, as we're seeing patients in the convalescent and chronic stages of disease, we are dealing with symptoms such as chest pain, arrhythmias, or patients presenting with LV dysfunction. And in these patients, we are now using imaging to look at more chronic complications from the disease. Certainly, the most important imaging modality has been ultrasound, and one of the big advantages of ultrasound has been the portability. And one of the things we deployed at my hospital, Brigham and Women's Hospital, is point-of-care ultrasound systems, which you can see on the slide here. These were made available in every one of our COVID ICUs in step-down units. We've actually had 14 such units in my hospital. And we trained residents and fellows how to do bedside ultrasound. And similar to a FaceTime feature that many of you have on your phone, they were able to call the Echo Lab and show us how they are acquiring the images. And we were able to sit in the Echo Lab and view their images and sometimes give people guidance on how to acquire. So this was really a live acquisition with feedback, which was very important. Well, before we proceed and show some examples, I want to start with kind of a general question to get people thinking about this. And that is, what is the most common echocardiographic finding in patients who are admitted with COVID-19? Was it A, decreased ejection fraction with no wall motion abnormalities, B, apical wall motion abnormalities, C, right heart dysfunction, or D, hyperdynamic LV function? Now, I know we don't have an audience response, but I expect some of you may think that maybe the ejection fraction is reduced in cases of myocarditis, and certainly there's cases of right heart strain. But by far the most common echo finding has been hyperdynamic LV function, which is maybe something all of you would expect. After all, these are very sick patients with systemic disease. And on this slide, you see an example using a point-of-care ultrasound. This is a handheld ultrasound, and it's amazing how well we can see things. And you can see here an example of hyperdynamic function in this particular patient that had ECMO. And you can see here an ECMO catheter in the IVC right atrium junction, something that we're able to image well. Other examples of echo findings in patients with COVID include LV dysfunction, which in many cases was myocarditis, or stress-induced cardiomyopathy. We will get to that. Or RV dysfunction, which was a common finding in patients with severe lung disease, specifically ARDS, where there is severe RV dysfunction. Now, in cardiology, people always think of the right ventricle as the forgotten ventricle, and it's for this reason that people get excited when there's research on it and people are paying attention to it, especially if that is on CNN. And this is coverage of a study from JACC Imaging that was featured at CNN. that right ventricular enlargement is a major predictor for mortality in COVID patients. This particular study was actually from Wuhan, China. It's a study of 120 patients that looked at an echo technique known as RV longitudinal strain to assess RV dysfunction. And it found that patient that had abnormal right ventricular strain, and more so than traditional measures of right ventricular function, such as fractional shortening, had a worse survival. Another study in JACC imaging that was recently published came from New York. And in this particular study, they looked at parameters of a dilated right ventricle, and showing that when the right ventricle was dilated, these patients had a far worse prognosis. Now, I think it's important for everyone in the audience to know that right ventricular dilatation or dysfunction can be due to multiple conditions. In my own hospital, when people see that, they always think, oh, this must be a PE. But the reality is that there is a wide differential diagnosis. We have seen more PEs in patients with COVID-19, but in many of these patients, this could be due to their lung disease and hypoxemic vasoconstriction. It could be due to other conditions such as cytokine-mediated, or in some cases, perhaps even direct viral damage to the right ventricle, essentially myocarditis involving the right ventricle. One of the challenges, however, in echocardiography that we all face as clinicians is patients that come with these echoes. And I'll tell you, the echo on the left is a 70-year-old male. The echo on the right is an 87-year-old male. Both came in with normal enzymes, but then had ST elevations and a sudden rise in their cardiac enzymes. And I would ask you, I know you can't answer, but I would still ask you to think, which of these patients had a STEMI, that is a myocardial infarction involving the LAD, in which cases Takotsubo? Well, the reality is you can't tell. If I had to guess, I would say that the image on the right is Takotsubo. That looks to me more like a Takotsubo or a stress-mediated cardiomyopathy. But the reality is that it's actually the patient on the right that had an acute STEMI, and the patient on the left that ended up having Takotsubo. And we will get to this patient, and I will show you how we ruled out coronary disease. But if we look at the patient on the right, let me just share with you the LAD angiographic findings. So this is an invasive angiogram showing severe stenosis here in the LAD. There was actually a large plaque burden as well. And this is a big wraparound LAD, which is why a myocardial infarction in this location involved the entire apex. So certainly you cannot use echocardiography to differentiate sometimes these different patterns. Now, early on in COVID-19, it was realized that one of the common presentations is patients presenting with ST elevation myocardial infarctions. And this is actually various examples from Twitter that I found, and this was published on Twitter well before it made it to any other journal. And one of the things that everybody was commenting on is that these patients, even though they had ST elevations, they did not have obstructive coronary disease. So people very early on recognized that not all the ST elevations are truly myocardial infarction. This hashtag COVID STEMI became popular. Ultimately, after Twitter, this made it to the New England Journal of Medicine. And this is a case series from New York, from several hospitals involving 18 patients. And interestingly, in this case series, all the patients had ST elevations, but most of them, 55%, did not have what was thought to be an MI. They just had myocardial injury, which is really a term that includes myocarditis or stress-induced cardiomyopathy or non-CAD etiologies. And you can see on the right side of the screen that in some of these cases, it's actually easy to tell that it's an MI based on the EKG. So if you have focal ST elevations and you have reciprocal ST depressions, in those cases, I think we can be very confident that this is likely an MI. However, in cases where you have diffuse ST elevations, it's not always clear. It tends to be myocarditis, but it can also be a focal MI. or sometimes there are focal ST elevations without reciprocal changes, and in those cases, often it could be either one. But one of the striking things from this study in the New England Journal of Medicine, which was also shown in a study from Wuhan, China in the European Heart Journal, is that patients that have elevated enzymes, irrespective of the mechanism, whether it's MI or whether it's myocardial injury, they have a really poor prognosis. In the New England Journal of Medicine case series, 72% of these patients died in the hospital, which is really a staggering number. So remember that case I showed you of the 87-year-old that we thought maybe has an MI, but he had Takotsubo? Well, the reason we know this was Takotsubo is because we were able to evaluate the coronary arteries. And really, if you want to make that diagnosis of stress-induced cardiomyopathy, you have to exclude coronary disease. This particular patient, who's 87, did have ST elevations in leads V2 and V3 that you can see on the EKG here. He did have a bedside point-of-care ultrasound showing apical akinesis. However, we then needed to rule out coronary disease. And in this case, we had a deliberation, should we do an invasive angiogram, or should we instead go to do a coronary CT angiogram? So a coronary CT angiogram would be an alternative to invasive angiography. And we decided actually to proceed with invasive angiography because the suspicion here was, because of the ultrasound findings, that this is more likely a stress-mediated cardiomyopathy and less likely an MI. But this is not the ideal patient to do a cardiac CT. By the time we did the CT, this patient was tachycardic. He was on multiple pressors. In fact, he was on 3 different pressors. He was on a vent, over-breathing the vent, so we couldn't control his respirations. His arms were down, and typically when we do cardiac CT, we like people to have their arms up on the scanner. We could not give him some of the medicines we give for CT, which are nitroglycerin and beta blockers to slow down the heart and dilate the arteries. And this was also a case we did in the middle of the night, where I was actually at home assisting the technologist in doing that. But despite all these limitations, we absolutely were able to get maybe not the prettiest images, but diagnostic images. And you can see here on the left side of the screen, these are axial images. And as this is playing, you can follow the coronary arteries. And we were able to see that the LAD in this 87-year-old male only had a small amount of calcified plaque, certainly just resulting in minimal stenosis. He did not have any obstructive disease. In the right coronary artery, this is an artifact that we can see with very fast heart rates called misread artifact, but I assure you this is a normal right coronary artery. So the point is that in this case, we were able to exclude coronary disease. When we do a CT, we can also look at function, and on this slide on the top end, you can see the left ventricle. You can see that there's severe left ventricular systolic dysfunction. We also, at the time of the CT, could see lung findings that are consistent with COVID-19 disease. And ultimately, this patient did well. His left ventricle recovered to normal function, which further supports a stress-mediated cardiomyopathy. And he was recently discharged home. As you can see on the bottom right here is a clip from the media after this patient was discharged home. We certainly celebrated every time somebody who was this sick was making it out of the hospital, particularly when they're 87. So on this slide, I want to share with you what is the role of coronary CTA in the evaluation of these patients with COVID and possible ACS. And on the left side, you see a guidance document from the Society of Cardiac CT, where we stated that CT can be used in carefully selected patients, where we use it to exclude obstructive coronary disease. And of course, we only want to do this in centers that have expertise in doing this particular test. Similarly, a joint multi-society document led by the ACC also suggested that when there are equivocal symptoms and equivocal findings, there can be a joint decisions between the emergency department, the interventional cardiology department, and the imaging program on whether to do a coronary CTA or to go to the cath lab and activate the cath lab. Certainly the point here is when patients need to go to the cath lab and we're suspecting a STEMI, they should go to the cath lab. But often in COVID-19, patients can have no coronary artery disease, and in some centers, cardiac CT can very effectively and efficiently replace the need for the cath lab. This slide actually shows the position statement from the European Society of Cardiology, and they stated that in patients with acute chest pain and suspected obstructive CAD, coronary CTA is the preferred non-invasive imaging modality because it is accurate, fast, and minimizes the exposure of patients. So this is the European statement. Now we use cardiac CT in other ways. So this is just an example of a male who is certainly much younger. This is a 45-year-old male. Came in also with symptoms that were suspicious for COVID and chest pain. And you can see on this slide a normal coronary CTA with no plaque and no stenosis. So something we were able to very quickly identify while this patient was in the emergency room and get him home. Here's another case that was interesting, and this illustrates how patients represent after COVID. So this is a 60-year-old male with diabetes and hypertension. He was actually admitted with COVID disease for 4 days, went home, but then 8 days later came back to the hospital with chest pain and shortness of breath, and EKG was normal in this particular setting. The troponins were very minimally elevated. So we did a coronary CTA, and in this case, what we're seeing is severe stenosis of the proximal left circumflex and also an occluded right coronary artery. So on invasive angiography, similar findings, again demonstrating the occluded right coronary artery on the bottom left and the severe stenosis in the left circumflex and OM branch on the top here was a very good correlation. Of course, that's one entity. Another entity is when we suspect myocarditis, which sometimes can be difficult to differentiate from MI. And I want to remind people that in COVID-19 disease, patients do have a prothrombotic state, which may predispose to MI. So this is a 22-year-old male who came in with chest pain, had elevated troponin, but also had some ST elevations on the EKG here. Perhaps not classic for MI, but certainly concerning. They are focal in the anterior leads. So for this 22-year-old male, we also did a coronary CTA, very nice CTA, no plaque and no stenosis in his coronaries. So given that, the leading diagnosis would be myocarditis. And we now did a MRI, and on MRI, we see a normal left ventricular systolic function. The walls of the ventricle are thick. We do see some increased enhancement, which is a feature we see sometimes with edema. And when we do dedicated images to look for edema or increased water content in the ventricle, we saw some edema in his infralateral wall. We saw some enhancement in an area we call subepicardial enhancement, which also can be consistent with edema in this case. So this person did well. And of course, he had a normal ejection fraction, so maybe we shouldn't be too concerned about him. But on the other end of the spectrum are patients like this, and this is a case report from JACC Imaging of a 44-year-old male who came in with an ejection fraction of 15% in what the authors called fulminant myocarditis. But the interesting thing here is that on MRI, there were findings of edema as well, but no necrosis. And even on biopsy findings, really findings consistent with edema with no necrosis. So for many of us who take care of patients with heart failure, when we think of fulminant myocarditis, we think of lymphocytic myocarditis or giant cell or conditions where there's a lot of necrosis of the myocardium. And what we're seeing in COVID is even patients with severe AF, perhaps this is a lot of stress-mediated cardiomyopathy where there's significant edema and LV dysfunction, but no necrosis. This is a slide just showing you the European guidelines, suggesting that MRI may be useful, but I think some of the important points here, which I would agree with, is that endomyocardial biopsy is not recommended in these COVID-19 patients. And after all, there's really no good recommendations for how to treat myocarditis that's associated with COVID-19. So this is a challenge. We could do MRI, we could look for myocarditis. It may help us prognostically, but from a diagnosis perspective, it might not always help us. I showed you cases with edema. I do want to also share with you that some patients can have scar. This is a patient that actually had a large amount of LG or scar, which we think was from COVID-19, but we always have to ask, could this be a pre-existing condition in this particular male? Most of the case reports in the literature have shown very little, if any, scar. This is one case report from the European Heart Journal Imaging Journal showing a young patient with a large amount of scar. So perhaps there are some individuals that can get a lot of scar, but that's the minority. So I think one of the big points is when you see patients with COVID-19 and LV dysfunction, there are a lot of different potential mechanisms. I'm go through all of these, but we touched about some of them. But is that in many cases, this could just be due to stress and findings of edema and very limited, if any, fibrosis. If we do not see any scar, I think it is fair to expect full recovery in those patients. And regardless, we should always think of other etiologies. I think one of the problems in this time is that we have, at least in my hospital, sometimes a cognitive bias. Anyone that comes in with LV dysfunction, we say, oh, this is COVID. But the reality is we have to think about all the other entities that all of us think about every day before jumping to the conclusion that this must be due to COVID. So I'm just going to end with one quick case showing how we avoided sometimes TEE. And this is a 52-year-old female that had staph bacteremia. This was right at the midst of the pandemic where we wanted to avoid TEE. So in this case, we decided to do a cardiac CT. And in cardiac CT, we can actually see the valves quite well. This is on the left, a picture of the aortic valve. On the right, you can see the pulmonic valve, both in short axis and in long axis. And we can see the mitral and tricuspid valves. Similar to what the echo showed in this patient, there was mitral annular calcifications. So on the CT, we saw all the valves well, and we have very good data that there's no vegetations, but we still had a high clinical suspicion here because this patient had persistently positive blood cultures. And we ended up doing a study known as a FDG PET. So this is a nuclear study that we often add on top of CT. And what we see here is FDG, which is glucose uptake along the area of the MAC. This is in the posterior mitral annulus. And ultimately, we concluded that this is a focal endocarditis. And I think one of the teaching points here is that patients that have mitral annular calcifications, that sometimes can serve as a nidus for infection for patients with Staph aureus. Of course, the other teaching point is that we can use both PET techniques and cardiac CT sometimes to evaluate for endocarditis. And this has been particularly important during COVID, where we actually tried to minimize TEEs because of its aerosolizing procedure. So this is just my summary slide. What I have shared with you that earlier in the disease, when we try to differentiate an acute coronary syndrome from injury, point of care ultrasound is important, as is cardiac CT if we want to rule out obstructive disease. Ultrasound, of course, is very important when you have patients in shock to see is there LV dysfunction, is there RV dysfunction, and we know that RV dysfunction carries a poor prognosis regardless of the etiology. And I think in the long-term picture, as we look at patients who recovered from the disease, when they now present with chest pain or arrhythmias, this is where stress testing, nuclear imaging, looking for microvascular disease that might be more common, or MRI, just looking for a scar, are all going to be important. So I'll pause there and turn it back to Dr. Chandrasekhar.
Thank you, Ron. That was an excellent coverage in a kind of a constricted time we gave you. Thank you. That was wonderful. As questions are being collected. Maybe I can start off, and then Vera can ask a question, and then Nat can. Can you just briefly describe what PPE usage you do for each of these tests? How do you plan an echo? How do you plan? Do you go to POCUS? Do you do more? How do you plan for your CT, TEs, and MRs? Go ahead.
Yeah, so I think it's a big question in all our labs. Obviously, we use full PPE for everybody that has patient interaction. The highest risk procedures are TEE, where in our lab we have been using a full PPE, which includes an N95 mask and a facial shield. So that's the highest level of PPE that we're doing for echocardiography. For other tests in suspected patients, we use regular PPE. In patients with known COVID, sometimes we would use a higher level of PPE as well. I think one of the challenges now is trying to know who has COVID and who doesn't. In the acute phase, and even now, anyone admitted to our hospital has COVID testing. Now, as we're kind of exiting this acute phase, the big question that labs are asking is, should you do COVID testing in anyone referred for imaging or not? In our hospital, the rate of asymptomatic COVID infections is been found to be 1% to 2%. So we actually don't test everybody referred for imaging, but we do test them if they're referred for TEE.
Thanks, Ron. Vera?
Ron, can you share with us what you have done? Because obviously, point of care echo or point of care ultrasound is useful, but oftentimes a more substantial echo is required. Can you share with the group any special protocols that your lab has created, or what modification you have done with your regular protocol for echo to give the best information, but minimizing the amount of time that the person performing the echo is present in the room?
So that's a great question. So one of the things we did is we try to always use the point of care ultrasound first. Obviously, it can sometimes be more limited if you want to look for wall motion abnormalities in a difficult patient. But we actually got very good quality studies on the point of care ultrasound. I've shown some of them here. And one of the keys is that we actually had these machines in the actual COVID unit. So in every COVID unit, we had a machine. Our cardiology fellows and cardiology attendings, at least some of them, had their own point of care ultrasound. So they were able at the bedside to always do this first, and at least to look at whether the LV function is normal or not. That would be a point of care ultrasound findings. We also looked at lung findings to look for edema. In fact, we had one patient in our hospital that had an arrest, and an intern who was trained in point of care ultrasound put it on the patient, identified a pneumothorax, and they did a bedside tap, and the patient recovered. So we used it quite extensively, but I think ultimately in some patients it might not answer the question, or it identifies findings where you now want to do a more comprehensive echocardiogram where you bring the entire echo machine to the patient, and that was done as well. But I think the advantage of the point of care is if you could do it well, it does minimize exposure, because it's the clinicians who are already there, already taking care of the patient, who are obtaining these images. And what I showed you is this kind of live interactive feature where even a non-professional like Dr. Rigglein, if she was doing the echo, she would get perfect images, but if an intern's doing it, they're going to be struggling a little bit. So it's a really nice feature to be able to give live feedback as somebody is acquiring the data.
Thanks, Ron. Nat has a question. Nat, you are muted. I think Nat is muted. While that's happening, there's an audience question. And both Vera, Nat, and Ron can answer. How do you get quality echoes when you have all the PPE, you have a face shield, mask, N95, and you do a bedside echo, you are the technician? How do you limit your protocol? What exactly should be done at that time?
I think you do limit the protocol in those cases sometimes to really identify what is the question at hand. Obviously, we're used to doing full echoes where we look at every valve and diastolic dysfunction and LV function. And a lot of these cases for bedside, you do have to limit the exam. I think PPE is a challenge, but even a bigger challenge is these patients often are ventilated. So when someone's on a ventilator, you cannot position them. And even to make that worse, we've proned a lot of our patients to improve oxygenation. So getting an echocardiogram in a prone ventilated patient is probably the most challenging echo you can think of.
I can share with you what our lab has done.
Hi, sorry to interrupt you. We will just be pausing the stream for like 5 seconds so that the slides are even more clear to the audience. I will just let you know when you can begin. It will be in just.
They have cardiac residua. Then,
yeah, you may start now. Thank you.
Go ahead, Nat. You had a question.
Okay. One question and one comment. You know, I talked to some of my friends, one in New York and one in Milan, a major epicenter. And I realized that the cardiac involvement is not that common in general, right, when you put all the patients together. And in our hospital, you know, we had not big population, about 50 patients or so. Only 2 had some issues, you know. LV dysfunction is one, and pulmonary thromboembolism is another, affecting the right heart. And we haven't come across any major arrhythmias. That's our experience. It varies depending on where one is.
Yeah, I think it's true. Obviously, when I show you these cases, this is a selected group. I mean, we had, this is among thousands of patients. Generally, elevations in troponin have been found in 10 to 30% of patients. And when those occur, I think more often those are myocardial injury. And this has to do with the fact that the ACE2 receptor that the virus uses to enter the cell is found in myocytes, but it actually is only found in the minority of myocytes. So it's not that all myocytes have the ACE2 receptor. But it's also important that endothelial cells also have this receptor. And this is why this is very much a virus that affects not just the myocytes, but the vascular system, and potentially that's a mechanism both for microvascular disease that we're seeing, and for both arterial and venous thrombotic disease. So you're right, cardiac manifestations are not the most common, certainly pulmonary are, but they're actually probably more common than we realize, and it's possible that a lot of them may be asymptomatic. And we are seeing patients presenting now with coronary disease, and obviously coronary disease is very common, so it's hard to say, is this because they had COVID 2 months ago, or is this because they're 60 and have hypertension? But we are seeing patients with cardiovascular disease now in the kind of more chronic stages presenting.
Thanks, Ron. That was a great discussion. We'll move on to the next topic. There's a question answer session in the end. We'll come back. I'm sure there are more questions. The next topic is mine, how to can you unshare? Yeah. So I will talk about an important topic that is coming up as a big issue. Can you see it?
Yes.
Okay. So what we need to do is to figure out what to do when you get a patient with heart failure. That's a very common situation. We often wonder what's the etiology of that heart failure. And one way to find out is advanced imaging. And so here is a chance for us to figure out how to approach patients with heart failure. So this is what we face every day, right? We know it's easy to find out heart failure with reduced ejection fraction, heart failure with preserved ejection fraction. But what happens after that? How do you know the etiology, especially if it's a dilated cardiomyopathy or ischemic cardiomyopathy? And what happens when you have so many different etiologies that can cause dilated cardiomyopathy, and we really don't know how to treat some of them, and some of them have great treatments. So here is an example of a lady who came with heart failure, and everything outlined in red is a possible cause for her heart failure. So the challenge for us is to find out what is causing heart failure in this patient, and then how do we treat it. So this is the EKG of the patient. Normally we would go over this, but it's the pretty common EKG: hypokalemia, U waves, QT prolongation, STs that are coming down. And then we go to the usual tests, and finally we ask what should be the next test. Any of these tests are okay, but in 2019, the ACC came out with their guidelines on what is the best test in each of this situation. And here is what they tell us. They tell us that for initial evaluation, it can be you start with an echo and then you go down with a bunch of other tests. So here is what we see in echo, right? So we can see LV function. We can see whether it is scarred. We can see LA function. We can see volumes. We can see remodeling. But what it doesn't answer to us is which of these causes are really operative at any time, correct? Sometimes you get lucky. So if you have the patient on the top here, like it's pretty clear that it is like LV non-compaction, you can make a diagnosis of what the patient has. But in other situations, you really don't know what's going on. And in many other times, echo is not diagnostic. For example, here is a patient with LV dysfunction. There is significant MR. There is a akinetic, probably scarred wall. And most of us would say this is clearly ischemic cardiomyopathy. But if you look at the angiogram, it turns out that it's a non-ischemic cardiomyopathy. So how do you figure out the etiology of heart failure becomes a very, very pressing question. And I would submit to you some of the guideline-based testing may or may not answer the etiology. Here is an example of a stress test. As you can see on the left side, reasonable normal function, which ends up with a wall motion abnormality. The same thing in other views. You can be reasonably certain that in this patient there is a high predictive value for identifying coronary artery disease as the etiology. But what happens in some other conditions where the echo looks so bad and you end up using contrast, right? So it still gives you some extra information, but at times you could have a stress test which looks not particularly bad, but the angiogram shows that there is a stenosis of the LAD. In such a situation, what we need to look at is some advanced imaging, or sometimes even perfusion defects that you can occasionally catch and get lucky. So in most situations, the guidelines would recommend that when you get a spectrum of LV dysfunction of various etiologies, you need to move on to the second phase, where after the initial diagnosis is made by the echo, then you go and find out what is causing the heart failure. So the questions that come up is, why did our patient develop heart failure? If she has multiple causes of heart failure and has coronary artery disease, which is the culprit? And what additional studies do you do? So there are again a bunch of studies that we can look at this phase. We obviously can look at stress echo, which has a high negative predictive value. We can look at strain imaging. Some people would go directly to an angiogram. Some people would go to a nuclear study. And some people might just go to a CMR. What do our guidelines tell us? Our guidelines show us that in the initial evaluation, echo was very good, but the other tests were given not a very high rating. But for the subsequent evaluation, there are only a few tests that would really sort out what is going on. Strain is one example. Dr. Rigolin will be talking more about strain in the coming talk. But there are certain situations where strain is diagnostic. If you look at the top, this is amyloid, the typical cherry on the top. The apex is spared. The rest of the myocardium is starting to get involved. And so this is thought to be very, very representative of amyloid. We'll talk more about it on subsequent days, how specific it is. So you can diagnose hypertrophic cardiomyopathy by a typical reduction in strain, and then in aortic stenosis, you can get random reductions in strain. So what did we do in our patient? Since we wanted to know whether it's ischemic or non-ischemic, we went and straight away did an angiogram. And this, not uncommonly, this is what we find. Sometimes you find disease that doesn't seem very tight on an angiogram, but may be obvious by some other methods, and FFR was done, and this was a two-vessel disease. The LAD was involved and the LCX was involved. So this makes it seem to be ischemic cardiomyopathy, but are we sure? And how can we be sure that it is ischemic cardiomyopathy? And what do we do next? That brings up the question, how good are we at diagnosing dilated versus ischemic cardiomyopathy? Normally, I would have thought this is a pretty straightforward thing, but advanced imaging is telling us that it is not really so easy to separate in every case. So here are 4 cases that I'm going to show you. The one on the middle shows a big anterior wall thinning and hypokinesia. Here the walls are preserved, global hypokinesia. And again, apical hypokinesia, global hypokinesia. If I ask you which one is dilated cardiomyopathy, which one is ischemic, or Takotsubo or amyloid, people will come up with various answers. And it turns out that sometimes we are wrong. And here is an example. What we thought was Takotsubo turns out to be myocarditis. What we thought was amyloid turns out to be a dense infarct in the anterior wall. What we thought was clearly ischemic heart disease with anterior wall motion problems and thinning turns out to have very little gadolinium, suggesting that maybe it's not all ischemic cardiomyopathy that is causing this problem. And given this fact is what brings us to the next part. When you have to do a comprehensive further evaluation of undefined cardiomyopathy, that is the time to come for CMR. You will see CMR has the highest rating in this area, and I would encourage all of the audience to start thinking about how you are going to use CMR in your practice, even if you don't do it. What is it that allows CMR such power? It's the ability to get precise tissue signatures. Here is an example, great morphology information, great scar information, which very little can be found in other tests, and a very nice way of looking at ischemia. Where does it take us further? Here are different morphologies just as examples. Look at the exquisite way you can find out. Dilated cardiomyopathy, big ventricles, amyloid cardiomyopathy, thick ventricles, pericardial effusion, ischemic cardiomyopathy, endomyocardial fibrosis, non-compaction, restrictive cardiomyopathy. There is really no other technique which can sort this out with such detail. CMR has something else that also we need to think about. It can identify different kinds of fibrosis. Here is an example of what's called replacement fibrosis, where you see this big scar, and that suggests that that area is dead. If the scar follows the subendocardial pattern in a coronary artery distribution, that is ischemic cardiomyopathy. If the scar follows some random pattern, it may not be ischemic cardiomyopathy. There's a second kind of fibrosis that is not detected by this technique, and that is called interstitial fibrosis. And for that, there is a special technique called T1 mapping. We won't go into it today, but that together with late gadolinium enhancement is an excellent technique to find out etiology of heart failure. What else can CMR do? It can also tell you edema. Here is a patient with 2 infarcts, one here and one here. How do you know which one is acute and which one is chronic? We can do edema imaging. The infarct which has acute edema is the acute infarct, the other one is chronic. There are lots of literature you can read about it, but the question is, what do we do next in this patient? Do we know it's ischemic or non-ischemic? We saw the coronary artery had a problem only with FFR, but not with angiographic visual stenosis. So the guidelines do allow us, excluding CAD in patients with heart failure, angiography is recommended, but here is what happens when you do CMR. Here are examples of some patients. Look at this one here. This is a patient with dense anterior wall infarct, but no coronary obstruction. So no matter what the coronaries say, we can conclude that this is ischemic cardiomyopathy and a dense enhancement, but some incidental coronary artery disease, we'll still have to call this non-ischemic. There are some reversible causes of heart failure. Echo is reasonably good here. Here is a patient of myocarditis who came with this echo in the morning, and a repeat echo later that night shows severe MR and severe LV dysfunction. These are the things which echo is very helpful. We went straight for an endomyocardial biopsy, and giant cell myocarditis treated with full recovery. So CMR is providing ability to avoid biopsy in these patients with myocarditis, and we are starting to see more and more of these. You of course know MINOCA, where you can have an acute myocardial infarction like pattern, some late gadolinium enhancement and accompanied by edema, and the Lake Lewis criteria now tell you how to identify myocarditis. Then of course stress cardiomyopathy, which we'll cover at a later time. The classic pattern is apical ballooning or some ballooning, no late gadolinium enhancement, but the presence of edema. Okay, so patterns of scars are important. As I told you, a subendocardial scar following a distribution of a coronary artery disease is usually a coronary artery disease related problem. A non-coronary artery distribution can be sarcoid, they can be mid-wall in dilated cardiomyopathy, and sometimes in myocarditis. There are lots of papers looking at this. The scar is prognostic. Both the location of the scar and the extent of scar can predict how people will die. And then the T1 mapping technique that I recently talked with you is also coming out in a big way. So how do we diagnose cardiomyopathy in 2020? We do cine, we do fibrosis, macroscopic scar. We forget tagging for a minute. We do microscopic scar with T1 mapping. We can look at edema and infiltration. And so the take-home message, my last slide, is echo is still the workhorse for the initial diagnosis and management of these patients. CMR reduces the unexplained DCM category with providing function, ischemia, and tissue properties. In my practice, we are using CMR more and more to determine who gets an ICD or doesn't get an ICD and for prognosis. But remember, it's expensive and needs training. Thank you. Happy to take questions.